Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Our lecture today is very important. It is about menopause and hormone replacement therapy. According to the guidelines, so what are the objectives of this lecture? Introduction, menopausal symptoms. What about hormone replacement therapy? Its indication, complications, advantage and disadvantage, and the types. Alternatives to HRT, hormone replacement therapy guidelines. Okay, with a marked increase in longevity, women now spend third of their lives in the post-menopausal period. And you should know also that a third of total female population are in menopause. Therefore, they would have to cope with the post-menopausal syndrome and they face the consequences. Hormone replacement therapy doesn't suit everyone, so every case is a very special case. So what you can give to one woman, you can't give it for another woman. Each woman needs to be aware of the benefits and the potential risks of hormone replacement therapy. What are the menopausal symptoms? Under two big categories, the physical and the psychological. Physical include hot flashes or flashes and the night sweats, palpitation, joint and muscle pain, urinary symptoms, frequent urination, involuntary urination, when laughing or coughing, and frequent urinary tract infections, weight gain and headache, sexual changes like loss of libido and the vaginal dryness during intercourse, skin and hair changes, dry skin, changes to appearance of the skin, texture or tone of the skin, and increased facial hair. This is the physical symptoms that can happen. What about the other category, which is psychological symptoms? Psychological symptoms include depression, anxiety, irritability, tiredness, and poor sleep, forgetfulness, loss of concentration, loss of libido, tiredness, and poor sleep. What about long-term menopausal effects? This is very important, really, like osteoporosis, atrophy of the vagina and the urethra, cardiovascular disease. So what about hormone replacement therapy? So as regard the indications for hormonal replacement therapy, the indications include relief of short-term vasomotor symptoms like hot flashes, for example, alleviate low mood as a result of the menopause. In cases with urogenital atrophy, also in cases with premature ovarian insufficiency. When this happened, it happened before 40 years age. So the woman in need for hormone replacement therapy. Prevention of osteoporosis in postmenopausal women at high risk of future fractures. These are the indication of hormone replacement therapy. Okay, you should evaluate each human before you prescribe hormone therapy. So all candidates for hormone therapy should be thoroughly evaluated with a detailed history, complete physical examination, general, abdominal, and pelvic examination to exclude any pelvic organ enlargement or masses. Okay, and some investigation may be needed like CBC, blood sugar level, fasting lipid profile, pelvic ultrasonography, and the comment on the endometrial thickness, which is very important, and the cutoff in post-menopause is less than 4 millimeter. And also mammography. Okay? All this for proper diagnosis and identification of any contraindications. So, you should do that before prescribing any hormone therapy. So what about the advantage and disadvantage of hormone replacement therapy, or what's called the pros and the cons? Pros and the cons, let us start with the pros or the advantage. Excellent symptom management. Decrease rates of colon cancer, osteoporosis, urinary tract infection, and depression. Preservation of joints, teeth, and skin. What about the disadvantage of hormone replacement therapy or cons? Coronary heart disease. Hormone replacement therapy doesn't help but might hurt. Okay, as regard the coronary heart disease. Increased risk of stroke and the pulmonary embolism, thromboembolism. Increased rates of breast cancer, increased gallbladder disease, increased rates of lupus, and vaginal bleeding. So what about hormones and the drugs used in case of postmenopausal symptoms? Estrogen, progestogen, STEAR, which is selective tissue estrogenic activity regulator, for example, tibolone, one of the selective tissue estrogenic activity regulator, tibolone, which has an estrogenic action and progestogen action and androgenic action. And also it is called gonadomimetic. This tibolone is called also gonadomimetic. It has estrogenic action, progestogen action, and androgenic action. And the SERM, like raloxifene, which is SERM is abbreviation of selective estrogen receptor modulator. These are components which act like estrogen in certain place and anti-estrogen in certain places or other organs. So we have in the management or treatment in hormonal and the drugs treatment, estrogen, progestogen, or combination of both, tibolone or raloxifene. Tibolone is the one of the STEAR, raloxifene is the one of the SERM. This is the second generation of the SERM. What is the first generation of SERM? Tamoxifen. So raloxifene is the second generation of SERM. Okay, what about routes of treatment? Either oral, transdermal, implants, local vaginal creams, rings and pessaries, or hormone-releasing intrauterine system like levonorgestrel-releasing intrauterine system, or what's called the Mirena, for example. Let us know some terminology. Hormone therapy, HT. What does it mean? Treatment with one of several available estrogen, with or without progestin, and without reference to its route of delivery. Whatever the route of the delivery, this is called hormone therapy. Estrogen therapy, or in abbreviation ET, estrogen only therapy. Estrogen and the progestin therapy, in abbreviation EBT. Combination estrogen and the progestin therapy. Hormone replacement therapy, this is an old term, HRT, usually denoting combination estrogen and progestin therapy. Estrogen replacement therapy, ERT, also an older term denoting estrogen only therapy. So you should be familiar with this abbreviation, okay? Okay, what about the various schedules of hormone therapy? Estrogen taken daily if you are using estrogen. Estrogen is used alone in women who have undergone hysterectomy. Okay? Cyclic or sequential regimen in which progesterone is added for 10 to 14 days every 4 weeks. Continuous combined regimen in which estrogen and progesterone are taken daily. So there is difference between sequential regimen and the continuous combined regimen. In sequential regimen, we start with estrogen, okay, over the month, but in the last 14 days, we add progesterone. In continuous combined regimen, we start with estrogen and progesterone and continue from the start, okay? Okay. Estrogen only if the case have undergone hysterectomy before, because we are afraid from the risk of estrogen alone on the endometrium, causing endometrial hyperplasia, endometrial carcinoma, and so on. Okay, what about the estrogen most commonly prescribed? The most commonly prescribed are conjugated estrogen that may be equine, so we call it conjugated equine estrogen, or CEE, or synthetic micronized sub-17 beta estradiol and the ethinyl estradiol. Of course, the conjugated estrogen is better. The progestins that are used commonly are either medroxyprogesterone acetate or norethindrone acetate. This is the two types of progestin can be used. One of them. Okay? Okay. So we know now which estrogen can be used and which is the preferred one or commonly prescribed, and the progestins used. What about the regimen, the dosage? The dosage varies, but the most commonly prescribed hormonal therapy is combined estrogen and progestin in the form of 0.625 milligram per day conjugated equine estrogen plus 2.5 milligram per day medroxyprogesterone acetate in women with an intact uterus. Okay? But there is another dose and preferred than this, the lower dose preparation. What about the lower dose preparation? We use 1.5 milligram per day of medroxyprogesterone acetate with either 0.45 milligram or 0.3 milligram per day of conjugated equine estrogen, and this becoming increasingly popular. And I advise every doctor to use the lowest dose, the lowest effective dose. So if you use the conjugated equine estrogen 0.3 milligram per day plus 1.5 milligram per day medroxyprogesterone acetate, this is better choice. Okay, what else can be used? The Mirena intrauterine system or levonorgestrel releasing intrauterine system. Please look to this picture. This is the original Mirena, levonorgestrel releasing intrauterine system, and this is another version, shorter, used in postmenopausal lady because the uterus is small or atrophied. So they designed a smaller Mirena for postmenopausal lady. What else? The amount of levonorgestrel released every 24 hours is 20 microgram per day for the original Mirena. Okay? But in post-menopause 1, the smaller version released only 10 microgram every 24 hours. Okay? So, what is important in follow-up of patient under hormonal therapy? Review the patient after 3 to 4 months if hormonal therapy has been started or changed, then at least annually thereafter, unless there are clinical indications to review earlier. What you are going to do in each visit. At each review appointment, assess symptom control, tolerability, and the compliance, check blood pressure, reassess risk relating to current choice of HRT. So, what about reassessing risk relating to current choice of HRT? Okay, those with long-term use of sequential combined hormonal therapy for more than 5 years may be associated with a small increase in risk of endometrial hyperplasia and endometrial cancer. Also, you should know that you may consider a reduction in dose of HRT as patients get older. So, with advancement of the age of the postmenopausal lady, try to reduce the dose of HRT to prevent the risky complications. What else in reassessing risk relating to current choice of HRT, you may recommend switch to transdermal preparation where appropriate to reduce risks of venous thromboembolism. And by the way, the most popular hormonal therapy is transdermal preparations, whatever containing estrogen only or estrogen and progesterone, a combination of both. This is the first choice usually. Okay, what else you should do during follow-up? Be sure that the patient keeping up to date with the national screening programs, including breast screening program, using mammogram, and cervical screening program for cervical carcinoma. So, to avoid breast cancer and cervical carcinoma, you should tell her, please follow the screening program. Mammogram for the breast and cervical screening programs. Also, regular breast self-examination is important, and ensure patient is clear on how to perform this, how to perform breast self-examination is important, and ask for advice if she found something abnormal. Lastly, bone health optimization. So, please emphasize the importance of all of this. So, what about the adverse effect of hormonal therapy? Usually it is transient or temporary, like nausea, bloating, fluid retention, weight gain, breakthrough bleeding, breast tenderness, mood swings. Especially, this may happen with the use of relatively androgenic progesterone. And also, as I said before, nausea, bloating, weight gain, breast tenderness, breakthrough bleeding, and mood swings, as I said, those using hormone therapy, which is relatively androgenic progesterone. So what about the potential risks of hormone therapy? We have to comment on breast cancer, endometrial cancer, thromboembolism, biliary pathology. Breast cancer, use of combined hormonal therapy increases risk for breast cancer after 5 years of continuous regimen. Endometrial cancer and uterine hyperplasia increase risk with the use of unopposed estrogen. We said before, you shouldn't use estrogen therapy alone in women have a uterus. Okay? Estrogen therapy alone may be used in those with hysterectomy. Thromboembolism, increased risk with the use of combined estrogen or estrogen or combined or estrogen only hormonal therapy. This is well known complications. Biliary pathology, increased risk with the use of estrogen only or combined estrogen and progesterone hormonal therapy. This is the potential risk of hormonal therapy. Special comment I want to tell you about, which is hormone replacement therapy and migraines. Okay, for women experiencing migraine, transdermal estrogen should be used when indicated. Okay, so don't use oral preparation, but you can use transdermal estrogen. Migraines are often triggered by fluctuation in hormone levels. A patch, the transdermal application of a patch, provide stable release of hormones and therefore is the preferred option. But use the lowest dose of estrogen that control vasomotor symptoms. Start with the lowest dose and increase gradually if required. I hope the lowest dose can control the symptoms. Okay? What else? Where progestogen is required, continuous delivery is recommended with preparation such as 52 milligram levonorgestrel intrauterine device or transdermal norethindrone as in combined batches. Okay, so you may give the, if you are in need for giving the patient progestogen, you can use either the small Mirena 52 milligram levonorgestrel intrauterine device. Of course, this is the whole dose of this levonorgestrel intrauterine system. Okay, which is releasing 10 microgram per day. Okay, or you can use the transdermal norethindrone as in combined batches. Okay, what about selective tissue estrogenic activity regulator, or the abbreviation STEAR? And for this example, the tipolone. Tipolone is a synthetic steroid with estrogenic, progestogenic, and androgenic activity. It's called also gonadomimetic. The mechanism of action of tipolone involves the formation of three active metabolites. Two of them, 3-alpha and 3-beta hydroxytipolone, have estrogenic effect. And the third is the delta-4 isomer, has progestogenic and androgenic effect. So we have in tipolone 3 active metabolites. 3-alpha and 3-beta hydroxytipolone have estrogenic effect. And the other metabolite, the third metabolite, is delta-4 isomer, has progestogenic and androgenic effect. Tipolone use in postmenopausal women has demonstrated effective alleviation of vasomotor symptoms, genitourinary syndrome of menopause, GSM, in abbreviation, increase in bone mineral density, and positive effects on cardiovascular and the central nervous system. What about selective estrogen receptor modulator with the abbreviation SERMs? As I said before, as raloxifene, SERMs are a class of non-hormonal drugs that selectively mimic or antagonize the effect of estrogen at various target organ sites. They work as estrogenic in certain organ and they work as anti-estrogenic in other organs. They have beneficial effect on bone and the cholesterol metabolism and can be offered as an alternative to traditional hormonal therapy for prevention and the treatment of osteoporosis in postmenopausal women. Tamoxifen is the first SERM that has been successfully tested for the prevention of breast cancer in high-risk women. We know that tamoxifen, as I said, one of the SERM, this is the first generation, it acts like estrogen on endometrium and estrogenic effect on endometrium and on bone, but anti-estrogenic on breast. So they are using tamoxifen for prevention of breast cancer in high-risk women because it has an anti-estrogenic effect on the breast. The other example, which is raloxifene, this is the newer SERM or second generation of SERM, originally developed for osteoporosis, also appears to have preventive effect on breast cancer incidence. What about alternatives to hormone replacement therapy or other line of treatment? Other line of treatment, including lifestyle recommendation. You should start with this lifestyle recommendation to alleviate symptoms by regular exercise, healthy body mass index, wearing lighter clothing, sleeping in a cooler room with silk pillows, using a fan, reducing stress and avoiding possible triggers, for example, spicy foods, alcohol, caffeine, and smoking. So ask the woman to try to reduce the use of spicy food or stop or reduce the spicy food, alcohol, caffeine, and smoking. Stopping of this can improve the condition, plus what I said before, regular exercise, healthy body mass index, wearing lighter clothing, sleeping in a cooler room, and so on. Balanced diet and the supplement. Eating a balanced diet of veggies, calcium, soy-based foods can go a long way towards relieving symptoms, but in some cases, supplements may be warranted. And by the way, I wanted to tell you in Japan, they found the lady there not complaining of menopausal symptoms. Why? Because in their food there is soybeans. They are using more soybeans. And soybeans containing phytoestrogen like isoflavone, which a plant estrogen which can reduce the symptom. They are taking on the average per day 25 up to 50 milligram per day of this isoflavone in soybeans. And you should know that 1 gram of soy gave 1 milligram of isoflavone, which is a phytoestrogen or plant estrogen. Okay, that's why the Japanese woman rarely complaining of menopausal symptoms. Breast best supplements for menopause include calcium, vitamin D, and the ground flax seed. What about the use of bioidentical hormone therapy? So what is the bioidentical hormone therapy? Bioidentical hormone therapy uses processed hormone that come from plants. So it is plant origin. Estrogen, progesterone, and the testosterone are the most commonly used bioidentical. And there are controversies about about the use of this bioidentical hormone therapy. The United States Food and Drug Administration, FDA, has approved certain types of bioidentical hormone. Other forms of bioidentical hormone are custom made by pharmacists based on health care providers' prescription. These are compounded bioidentical hormones. So I have two categories of bioidentical hormones. One FDA approved and the other compounded bioidentical hormones. This compounded bioidentical hormone are custom made by pharmacists based on health care provider prescription. Both the FDA approved and the compounded hormones come in various doses and forms: pills, creams, gels, sprays, and vaginal inserts. You should know that there is a lack of high quality data on the safety and the efficacy of custom compounded bioidentical hormone therapy for the management of menopausal symptoms. Okay? There is no FDA approved testosterone formulation for the management of menopausal symptoms. And the clinician and the patient should use assured decision-making framework when considering the use of compounded testosterone for this indication. Okay? We should know this very well. And based on the lack of safety data and the inability to remove the pellet, American College of Obstetricians and Gynecologists recommends preparation other than pellet therapy for the delivery of testosterone. They don't want the woman to take the pellet therapy. Okay? Other forms may be patches and so on. Okay? So there is controversy about the efficacy and the safety. There is no FDA approved testosterone formulation for the management of menopausal symptoms. This is important items. Let us go to hormone replacement therapy guidelines. These guidelines depend on two big studies. One in United Kingdom, the Million Women Study, and the other in USA, Women Health Initiative Study. Okay, let us start with the short note about the Million Women Study. A national study of women health involving 1.3 million United Kingdom women aged 50 and over between 1996 and 2001. The study is looking at how HRT affects a woman's breasts and other aspects of her health. 66 national health surveys breast screening centers were involved in this study. Okay? The other big study, Women Health Initiative study. Women Health Initiative study in the United States began in 1997 and was scheduled to be completed in 2005. However, researchers halted the study on May 2002. Why? Because they felt that the health risks for participants taking hormone replacement therapy outweighed the possible benefit of HRT. So they stopped it at 2002. Okay? Okay. Let us know the guidelines according to these two big studies in certain items. The first item is HRT and the menopausal symptoms. What about vasomotor hot flushes? HRT is an effective treatment for hot flushes. And this is grade A recommendation. Tibolone is effective for alleviating the severity and reducing the frequency of hot flushes. Unopposed estrogen may be effective for reducing sleep disruption. There is no evidence that HRT is effective for vasomotor symptoms such as headache and dizziness. What about urogenital symptoms with HRT? Low dose topical estrogen or oral estriol is an effective treatment for vaginal dryness. Tibolone has been shown to be effective for vaginal dryness. Topical estrogen replacement therapy for 6 months decreased the incidence of recurrent urinary tract infection. What about psychological symptoms? Estrogen is not an effective treatment in elderly women with established Alzheimer's disease. The addition of low doses of androgen to hormone replacement therapy provides relief in women with either premature or surgical menopause who suffer from low libido for less than 2 years. What else? Tibolone is effective in providing relief from low libido in postmenopausal women. Estrogen replacement therapy is not an effective treatment for loss of libido in postmenopausal women. Combined hormone replacement therapy doesn't improve cognitive function in women aged 65 or more. What about HRT and the risk of cancer? As regards the risk of breast cancer, continuous combined HRT was associated with an increased breast cancer risk if used for 4 years or more. However, this increased risk disappears within 5 years once use is discontinued. Use of tibolone is associated with an increased risk of invasive breast cancer. What about risk of endometrial cancer? Unopposed estrogen therapy shouldn't be used in women with uterus because of an increased risk of endometrial cancer. Women who have had hysterectomy may take unopposed estrogen therapy. Unopposed estrogen therapy shouldn't be used in women with a uterus because of an increased risk of endometrial cancer, as I said before. Risk of endometrial cancer. What else? Combined continuous regimens offer better protection of the endometrium than sequential regimen. Okay? combined continuous regimen offer better protection of endometrium than sequential regimen. Continuous combined estrogen plus progestogen. When I say combined, I mean estrogen plus progestogen. Okay? So, continuous combined hormone replacement therapy decreases the risk of endometrial cancer compared to the risk in women who have never used HRT. The synthetic HRT product tipolone increased the risk of endometrial cancer when used for more than 3 years compared to the risk in women who have never used HRT. What about risk of ovarian cancer? Incidence of ovarian cancer increased with increasing duration of use of HRT. Estimated duration of use at time of diagnosis 7.7 years. And it is said in some studies the use of HRT more than 10 years increases the risk of ovarian cancer. So, the use of HRT more than 7.7 or more than 10 years increases the risk of ovarian cancer. What about colorectal cancer? Combined HRT use is associated with decreased risk of colorectal cancer. What about venous thromboembolism, which is something very important? It is recommended that in women with a previous venous thromboembolism with or without an underlying hereditary thrombophilia, oral HRT should usually be avoided. It is recommended that when a woman who is on HRT develops venous thromboembolism, HRT should be discontinued. In high-risk women with an underlying thrombophilic trait, HRT is not recommended. Selective estrogen receptor modulator should be considered to carry the same risk of thrombosis as estrogen-containing HRT. Prior to commencing HRT, personal history and the family history assessing the presence of venous thromboembolism in a first or second degree relative should be obtained. HRT should be avoided in women with multiple pre-existing risk factors for venous thromboembolism. It is recommended that if a woman requires to continue on HRT after venous thromboembolism, long-term anticoagulation should be considered. What about HRT and coronary heart disease? HRT is contraindicated for secondary prevention of further coronary disease because of lack of documented efficacy and the possible early excess mortality. Heart and the estrogen plus progestin replacement study report that standard doses of estrogen progestin therapy increased the risk of coronary heart disease in the first year of therapy. Randomized controlled trials have found an increased risk of coronary heart disease in women who started combined estrogen progestin therapy more than 10 years after menopause. So, the beginning of her hormonal replacement therapy after 10 years of menopause. Newly menopausal women have a lower relative risk compared with older women. What about hormone replacement therapy and STRUC? In randomized controlled trials, estrogen only and the combined hormone replacement therapy increase the risk of STRUC, mostly ischemic, compared with placebo. In tibolone users, the LIFT study. This is an abbreviation of long-term intervention on fracture with tibolone. In this study, they identified a significantly increased risk of stroke, mostly ischemic. The risk increased from the first year of treatment. And this study identified a significantly increased risk of stroke 2.2 times. 2.2 times. And this mostly ischemic. Okay? This is as regard in tibolone user. Tibolone user is one of the STEAR. You remember when I said that at the start of the lecture, selective estrogen tissue regulator. What about HRT and the osteoporosis? HRT and the biphosphonates has positive effects on bone density in postmenopausal women, whether or not they have osteoporosis. Maintaining HRT use decreases the risk of vertebral and non-vertebral fractures in women after surgical menopause, early postmenopausal women, and in women with established osteoporosis. Selective estrogen receptor modulator may be useful in the prevention of vertebral fractures in women who cannot use HRT or biphosphonates. Selective estrogen receptor modulator, as you remember, one of the example is the raloxifene or tamoxifen. What about HRT and gallbladder disease? Combined HRT is associated with increased risk of gallbladder disease and biliary tract surgery. This is the end of my lecture. I hope it was beneficial for you. This is my box published on Amazon. Textbook of Obstetrics, textbook Gynecology, contraception handbook, multiple choice question book, medical disorder in pregnancy and the gynecologic oncology, and the newest one published recently on Amazon, updates in obstetrics and the gynecology. Please try to find all these books on my site on Amazon. This red link, I'll put it in a comment. And you can read more about menopause in a previous lecture via my site on YouTube with blue link here. I'll write it also in a comment. And you can find many pictures of my operations on the blog spot through this link. Thank you, everybody. Wishing you all the best.